Your kidneys are filtering your entire blood supply right now, every drop of it, approximately once every 30 minutes. 24 hours a day, 7 days a week, without pause, without rest, and almost entirely without your awareness. Each kidney contains roughly 1 million microscopic filtering units called nephrons, and together they process around 180 liters of blood plasma every single day, returning 99% of it to circulation while concentrating the waste into the 1 to 2 liters of urine your body produces. That process is so continuous, so efficient, and so invisible that most people have no idea it is happening until it starts to fail. Chronic kidney disease is the condition that medicine most consistently diagnoses too late. Not because the signs are absent. They are present, often for years, but they are non-specific, easily dismissed, and almost never presented to the public as a recognizable pattern pointing to a specific organ under threat. Swelling in the legs that gets attributed to long days on your feet. Fatigue that is explained away as poor sleep or stress. A change in urination that seems too minor to mention. An itch with no rash that your GP cannot immediately explain. These are not background noise. In the right combination, they are a kidney struggling to maintain the filtration, hormonal regulation, and electrolyte balance that every other system in your body depends on. Chronic kidney disease affects approximately 1 in 7 adults in the developed world. Most of them do not know it. The condition is clinically silent through its early and middle stages. eGFR, the measure of kidney filtration capacity, can fall to less than half its normal value before any symptom becomes obvious enough to compel investigation. By the time a patient arrives in an emergency department with end-stage kidney failure, the disease has typically been present and progressing for a decade or more. Understanding what the early and intermediate signs actually look like and why the kidneys produce them is the most important thing this video can give you. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly 10 years in the AA and EE, I have seen what chronic kidney disease looks like at the point where it can no longer be ignored, and I have seen it far too many times in patients who have been symptomatic for years without the pieces being connected. Fluid overload, dangerous electrolyte imbalances, accelerated cardiovascular disease, dialysis, these are not sudden events. They are the end of a long trajectory that had visible signs along the way. My goal now is to make those earlier signs recognizable, so that people have the information to act before the trajectory becomes irreversible. If you are watching this, you are probably someone who takes their health seriously, or who has noticed something that has been bothering them and is looking for a clear, honest explanation. I want to make you a direct promise. I will keep creating the most rigorously researched and clearly explained content I can, grounded in real clinical experience and the latest evidence. All I ask in return is that you give this channel a real chance and hit the subscribe button right now. If you get to the end of this video and feel you have not learned anything genuinely new, please unsubscribe, no hard feelings at all. But if you give me your time and attention, I will give you everything I have learned from a decade on the front line of medicine. Please hit subscribe, help this channel reach more people who need it, and let us get into it. To understand why kidney failure produces the specific signs it does, we need to understand what the kidneys are actually responsible for, because they do far more than filter urine, and each of their additional functions produces its own category of symptoms when it fails. The kidneys perform 5 distinct physiological roles that are each essential to the body's moment-to-moment stability. The first and most widely recognized is filtration and waste excretion. The nephrons, those million microscopic filtering units in each kidney, work by forcing blood plasma through a membrane under pressure, retaining large molecules like proteins and red blood cells, while allowing small waste molecules like urea, creatinine, uric acid, and drug metabolites to pass through into the filtrate. That filtrate is then selectively modified as it travels along the nephron tubule, with useful substances like glucose and electrolytes reabsorbed back into the bloodstream and waste concentrated into urine for excretion. When filtration capacity falls, measured clinically by the estimated glomerular filtration rate, or eGFR, these waste products accumulate in the blood, a state called uremia, which is toxic to virtually every organ system. The second role is fluid and electrolyte balance. The kidneys are the primary regulators of the body's sodium, potassium, calcium, phosphate, and bicarbonate levels. These electrolytes govern nerve conduction, muscle contraction, cardiac rhythm, bone mineralization, and acid-base chemistry. The kidneys maintain them within extraordinarily narrow ranges through continuous fine-tuned adjustments to how much of each is retained or excreted. When kidney function declines, this regulatory precision is lost. Potassium rises to levels that can cause dangerous cardiac arrhythmias. Phosphate accumulates and progressively depletes calcium from bone. Bicarbonate falls, tipping the body toward metabolic acidosis. Each of these electrolyte disturbances produces its own clinical consequences, and each can progress silently for months before producing an obvious symptom. The third role is blood pressure regulation. The kidneys produce a hormone called renin, which is the master switch of the renin-angiotensin-aldosterone system, the body's primary long-term blood pressure control mechanism. When kidney perfusion falls or sodium delivery to the nephron drops below target, renin is released, triggering a cascade that increases blood pressure through sodium retention and vascular constriction. In healthy kidneys, this system operates as a precise feedback loop. In damaged kidneys, the feedback becomes dysregulated, and hypertension, which both causes and is worsened by kidney disease, becomes established in a destructive cycle. The fourth role is erythropoietin production. Erythropoietin, EPO, is a hormone produced almost exclusively by the kidneys that signals the bone marrow to produce red blood cells. When kidney tissue is damaged and EPO production falls, the bone marrow receives a weaker stimulus and red blood cell production drops. The result is the anemia of chronic kidney disease, a specific, predictable form of anemia that is directly proportional to the degree of kidney functional loss and that produces some of the most prominent and debilitating symptoms of the condition. The fifth role is vitamin D activation. The kidneys perform the final conversion step that transforms the inactive storage form of vitamin D, calcidiol, into its biologically active form, calcitriol. Active vitamin D is essential for intestinal calcium absorption, bone mineralization, immune regulation, and muscle function. When kidney function declines, this conversion step fails, and even people with adequate dietary vitamin D intake and sun exposure develop functional vitamin D deficiency with consequences for bone density, muscle strength, immune competence, and cardiovascular health. Section 3b, the progression of kidney disease and why it goes undetected. Chronic kidney disease is staged from stage 1 to stage 5 based on eGFR, the estimated glomerular filtration rate, a calculation derived from serum creatinine levels that estimates how many milliliters of blood the kidneys are filtering per minute per unit of body surface area. A normal eGFR is above 90. Stage 3, the point at which most guidelines recommend nephrology involvement, begins at an eGFR below 60. End-stage kidney disease requiring dialysis or transplant typically occurs below an eGFR of 15. What makes this staging clinically alarming is that the kidney's reserve capacity means that symptoms are frequently absent until stage 3 or even stage 4. A person with an eGFR of 45, less than half of normal kidney function, may have no symptoms that they would independently identify as concerning. This is why the standard recommendation from nephrology guidelines worldwide is that anyone with diabetes, hypertension, a family history of kidney disease, or age over 60 should have their eGFR and urine protein checked annually. Not because they feel unwell, but because the disease will not tell them it is there until it is substantially advanced. Here are the 10 signs that your kidneys may be struggling, each one explained through the specific biological mechanism that produces it, so that you understand not just what to watch for, but why your body is producing that signal. Sign 1. Swelling in the legs, ankles, and feet. Peripheral edema. When the kidneys lose their ability to regulate sodium excretion, sodium begins accumulating in the body. Water follows sodium. This is a fundamental principle of osmotic physiology, and that excess fluid distributes into the tissues, gravitating to the lowest points of the body under the influence of gravity. The result is pitting edema in the ankles, feet, and lower legs, swelling that leaves a temporary indentation when pressed. This edema is also worsened in later stage kidney disease by falling albumin levels, as the kidneys begin losing protein through damaged filtration membranes, reducing the oncotic pressure that keeps fluid within blood vessels. Edema caused by kidney disease is bilateral, affecting both sides equally, and is typically worse at the end of the day. It does not respond to elevation alone and persists despite reducing fluid intake, which distinguishes it from the temporary ankle swelling many people experience after prolonged sitting or standing. Healthy kidneys retain plasma proteins, particularly albumin, within the circulation because their filtration membranes are selectively sized to prevent large molecules from passing into the filtrate. When those membranes are damaged by the inflammatory and mechanical insults of kidney disease, albumin begins leaking through into the urine, a condition called proteinuria. Protein in urine reduces its surface tension, causing it to produce persistent foam when it contacts the toilet bowl, in the same way that soap produces bubbles by reducing water surface tension. Foamy urine that persists present across multiple visits to the bathroom, not just occasionally, is one of the earliest detectable signs of kidney membrane damage. It can be confirmed and quantified with a simple urine dipstick test, which should be requested from your GP if this is a consistent observation. Proteinuria is not only a sign of kidney damage, it is also an independent accelerator of further kidney injury, making its early detection clinically significant in both directions. Sign 3. Changes in urination frequency and volume. Damaged nephrons lose their ability to concentrate urine efficiently, which disrupts the normal pattern of urination in predictable ways. Nocturia, waking multiple times during the night to urinate, is among the earliest functional signs of kidney disease and results from the kidney's loss of concentrating ability. The tubules can no longer produce concentrated urine during the overnight low-flow period, so urine production continues at a higher volume throughout the night. Some patients also notice an overall increase in urination frequency during the day as the kidneys try to compensate for reduced filtration efficiency with increased volume. In later stage disease, the pattern reverses. Urine output decreases as filtration capacity falls below the threshold required to produce adequate urine volume. Any persistent, unexplained change in urination pattern, particularly new nocturia in someone who previously slept through the night, warrants kidney function investigation. Visible blood in the urine, producing pink, red, or cola-colored urine, is always a symptom that warrants prompt medical investigation, regardless of whether it is painless or accompanied by discomfort. In the context of kidney disease, hematuria results from damaged glomerular filtration membranes, allowing red blood cells to pass into the filtrate. Microscopic hematuria, blood present in the urine at levels detectable by dipstick or microscopy, but not visible to the naked eye, is an even more common finding in early kidney disease and is picked up on routine urinalysis. While hematuria can result from urinary tract infection, kidney stones, or bladder pathology, it is always worth investigating the kidney as a source, particularly when it occurs without pain, without infection, or in the context of other kidney-related symptoms. The fatigue of chronic kidney disease has two primary biological drivers, both of which are specific to kidney functional failure. The first is anemia from reduced erythropoietin production. As described in the science section, falling EPO levels cause the bone marrow to produce fewer red blood cells, which reduces the oxygen carrying capacity of the blood and produces a profound, persistent fatigue that is qualitatively different from ordinary tiredness. It is a cellular oxygen debt fatigue. Muscles and organs are genuinely underfueled, and it does not respond to rest or sleep. The second driver is uremia, the accumulation of metabolic waste products that the failing kidneys cannot clear. Even at subclinical levels, uremic toxins interfere with mitochondrial energy production across multiple tissue types, compounding the fatigue produced by anemia. The combination produces a level of exhaustion that many patients describe as the most disabling aspect of their condition, and that frequently progresses slowly enough to be normalized as aging before its renal cause is recognized. Sign 6. Shortness of breath. Breathlessness in the context of kidney disease can arise through three distinct mechanisms, each of which reflects a different aspect of renal failure. The first is fluid overload. When the kidneys cannot excrete sufficient sodium and water, fluid accumulates not only in the periphery, but in the lungs, producing pulmonary edema that impairs gas exchange and causes breathlessness on exertion or when lying flat. The second is anemia. Reduced red blood cell count means the blood carries less oxygen per unit volume, and the respiratory system compensates by increasing the breathing rate to deliver more oxygen to tissues. The third is metabolic acidosis. When the kidneys can no longer excrete sufficient acid or regenerate bicarbonate, blood pH falls, and the respiratory system responds by increasing respiratory rate and depth to blow off carbon dioxide and compensate for the acidosis. Any unexplained breathlessness in a person with risk factors for kidney disease, particularly diabetes or hypertension, should prompt assessment of kidney function alongside cardiac and respiratory investigation. Generalized skin itching, in the absence of a rash or allergic cause, is a well-characterized but frequently under-recognized feature of moderate to advanced kidney disease. The primary mechanism involves the accumulation of uremic toxins, particularly urea and phosphate, in the skin and the activation of itch-mediating nerve fibers through a combination of calcium phosphate crystal deposition in the dermis and altered opioid receptor signaling. Uremic pruritus tends to be worse at night, affects the back, arms, and legs predominantly, and is characteristically unresponsive to antihistamines, a feature that should alert any clinician to consider a uremic rather than allergic cause. Research published in the Journal of the American Society of Nephrology has linked the severity of uremic pruritus directly to the degree of uremic toxin accumulation and phosphate dysregulation. It is one of the most distressing and quality of life impairing symptoms of kidney disease, and its presence in someone who has not been diagnosed with kidney disease is a clear indication for urgent renal function testing. Cognitive symptoms, difficulty with concentration, short-term memory, and mental clarity are a recognized feature of uremic encephalopathy, the neurological manifestation of kidney failure. The mechanism parallels that of hepatic encephalopathy. Accumulated metabolic toxins, particularly urea, middle molecular weight uremic solutes, and parathyroid hormone, cross the blood-brain barrier and disrupt neurotransmitter signaling, impair cerebral blood flow autoregulation, and produce mitochondrial dysfunction in neurons. In mild to moderate kidney disease, this manifests as a diffuse cognitive dulling rather than the dramatic confusion of advanced uremia. Patients describe it as thinking through fog, a persistent difficulty with word retrieval, concentration, and mental processing speed that they frequently attribute to tiredness, stress, or aging. It is important to note that kidney disease also significantly increases cardiovascular and cerebrovascular risk. Chronic kidney disease at any stage is an independent risk factor for stroke and vascular cognitive impairment, so cognitive symptoms in this context can have more than one contributing mechanism. As uremia progresses and the concentration of metabolic waste products in the blood rises, the gastrointestinal system begins to manifest symptoms that directly reflect the toxic environment. Nausea and loss of appetite are among the most consistent gastrointestinal features of moderate to advanced kidney disease and result from uremic toxin effects on the gastric mucosa, altered gut motility, and disruption of the hormonal signals that regulate appetite and satiety. A metallic or ammonia-like taste in the mouth, often described by patients as tasting like metal or as a persistent unpleasant taste they cannot clear, results from urea being converted to ammonia in the saliva by oral bacteria, producing a taste that is essentially the oral equivalent of uremia. This symptom is highly specific for significant uremia when it occurs in the absence of dental disease or medication that might explain it, and its presence should prompt urgent kidney function assessment. Hypertension is simultaneously one of the most common causes of chronic kidney disease and one of its most consistent early signs, creating a bidirectional relationship that can be difficult to untangle in clinical practice. When kidney function declines, renin production becomes dysregulated, activating the renin-angiotensin-aldosterone system in a sustained rather than episodic fashion, producing persistent hypertension through sodium retention and vascular constriction. This hypertension then further damages the glomerular filtration membranes through the mechanical stress of elevated intraglomerular pressure, accelerating the kidney disease that produced it. The clinical indicator that hypertension may have a renal component as opposed to being primary essential hypertension is resistance to treatment, blood pressure that requires 3 or more, antihypertensive agents to control, or that is persistently elevated despite adequate medication and lifestyle modification should always trigger kidney function assessment. Research published in the New England Journal of Medicine has demonstrated that even small reductions in proteinuria and blood pressure in patients with diabetic nephropathy significantly slow the rate of eGFR decline, underscoring the importance of identifying and treating the renal contribution to hypertension early. If you recognize several of these signs in your own experience, the appropriate response is not alarm, it is action. A blood test measuring eGFR and creatinine combined with a urine test for protein gives your GP the information needed to determine whether kidney function warrants further investigation. These are simple, inexpensive, and routinely available tests. The earlier a decline in kidney function is identified, the wider the range of interventions available to slow or arrest its progression. If this is giving you a clearer picture of what your body may have been trying to communicate, please take 5 seconds and hit the subscribe button. It genuinely helps this content reach more people who need it. Now let us talk about what actually protects kidney function and what can slow or reverse early stage decline. I want to be direct before we go further. If you recognize multiple signs from the list we just covered, the first and most important step is to see your GP and request kidney function testing, specifically eGFR, serum creatinine, electrolytes, and a urine albumin to creatinine ratio. Everything in this section is grounded in evidence about the biological conditions that protect kidney function and slow disease progression. But it complements clinical management, it does not replace it. Protection lever 1, blood pressure control. The single highest impact intervention. Hypertension is the leading cause of kidney disease progression worldwide, and its management is the intervention with the most consistent evidence base for slowing eGFR decline. The target blood pressure in patients with chronic kidney disease, particularly those with proteinuria, is more aggressive than the standard population target. Most nephrology guidelines now recommend a systolic blood pressure below 120 to 130 mmHg in this group. The class of antihypertensive medications with the most evidence specifically for kidney protection are the ACE inhibitors and angiotensin receptor blockers, both of which reduce intraglomerular pressure by dilating the efferent arteriole of the nephron, directly reducing the mechanical stress on the filtration membrane and slowing proteinuria progression. Research published in the New England Journal of Medicine demonstrated that ACE inhibitor therapy in patients with diabetic nephropathy reduced the rate of progression to end-stage kidney disease by approximately 50% compared to equivalent blood pressure control with other agents, an effect attributable specifically to the reduction in intraglomerular pressure rather than simply the reduction in systemic blood pressure. If you have chronic kidney disease and are not on an ACE inhibitor or ARB, this is a conversation worth initiating with your doctor. Protection lever 2, blood sugar management in diabetic kidney disease. Diabetes is the most common cause of end-stage kidney disease in the developed world, responsible for approximately 40% of all dialysis starts. The mechanism is direct. Chronically elevated blood glucose glycates the proteins of the glomerular basement membrane, disrupting its selective permeability, triggering local inflammatory responses, and progressively destroying nephron architecture. The evidence for tight glycemic control in preventing diabetic nephropathy is unambiguous. The landmark Diabetes Control and Complications trial demonstrated that intensive insulin therapy, reducing HbA1c by approximately 2 percentage points, produced a 54% reduction in the development of microalbuminuria, the earliest detectable sign of diabetic kidney damage. More recently, a class of diabetes medications called SGLT2 inhibitors, originally developed as glucose-lowering agents, have been shown in large clinical trials published in the New England Journal of Medicine to have direct kidney protective effects that are at least partially independent of their glucose-lowering action, reducing the risk of progressive kidney function loss by approximately 40% in patients with diabetic kidney disease. This represents one of the most significant advances in nephroprotection in a generation. Protection lever 3, dietary protein and phosphate management. The dietary management of chronic kidney disease is more nuanced than most patients are told, and it warrants careful explanation. High dietary protein intake, specifically protein above approximately 1.3 grams per kilogram of body weight per day, increases the filtration load on the remaining functional nephrons in a damaged kidney, accelerating the process of glomerular hyperfiltration that drives progressive nephron loss. Research published in Annals of Internal Medicine demonstrated that moderate dietary protein restriction in patients with non-diabetic kidney disease significantly slowed the rate of eGFR decline. This does not mean a severely protein-restricted diet, which carries its own risks of malnutrition and muscle loss. It means avoiding excessive protein consumption and obtaining dietary protein predominantly from plant sources where possible, which has the additional benefit of generating less acid load and less phosphate compared to equivalent amounts of animal protein. Phosphate management becomes increasingly important as kidney disease progresses, because the failing kidney's reduced ability to excrete phosphate leads to secondary hyperparathyroidism, a cascade of hormonal changes that accelerates bone demineralization, cardiovascular calcification, and further kidney damage. Reducing processed food consumption dramatically reduces dietary phosphate because phosphate additives used as preservatives in ultra-processed foods are absorbed far more completely than the organic phosphate in whole foods. Protection layer 4. Avoiding nephrotoxic medications and substances. Several commonly used medications and substances are directly nephrotoxic, capable of causing acute kidney injury or accelerating chronic kidney disease progression, and their risks are routinely undercommunicated. Non-steroidal anti-inflammatory drugs, including ibuprofen and naproxen, constrict the renal afferent arteriole and reduce renal perfusion pressure, causing acute kidney injury, particularly in the context of dehydration, intercurrent illness, or pre-existing kidney disease. Regular or high-dose NSAID use in a patient with stage 3 chronic kidney disease can accelerate progression substantially. Contrast dyes used in CT scanning carry a risk of contrast-induced nephropathy, particularly in patients with baseline kidney impairment, and adequate prehydration and dose minimization are standard precautions in this group. Certain antibiotics, particularly aminoglycosides and high-dose trimethoprim, require dose adjustment in kidney disease to avoid toxic accumulation. And proton pump inhibitors, as research published in the Journal of the American Society of Nephrology has demonstrated, are associated with an increased risk of interstitial nephritis and chronic kidney disease progression with long-term use at a population level. A medication review specifically assessing nephrotoxic risk, conducted by a GP or clinical pharmacist with access to a current EGFR, is an important step for anyone with diagnosed or suspected kidney disease. Protection layer 5. Hydration, exercise, and smoking cessation. Adequate hydration maintains renal perfusion and reduces the concentration of uremic toxins in tubular fluid, reducing the direct toxic exposure of tubular cells. The recommendation is not excessive fluid loading, which in advanced kidney disease can worsen fluid retention, but consistent maintenance of pale yellow urine as a practical indicator of adequate hydration throughout the day. Regular aerobic exercise has emerging evidence for direct kidney protective effects beyond its cardiovascular and metabolic benefits. Research published in the Clinical Journal of the American Society of Nephrology demonstrated that higher levels of physical activity were independently associated with slower EGFR decline in patients with established chronic kidney disease, through mechanisms including improved endothelial function, reduced systemic inflammation, and better blood pressure control. Smoking cessation is among the most evidence-supported interventions for slowing kidney disease progression. Nicotine causes renal vasoconstriction and endothelial damage, and smoking is an independent risk factor for both kidney disease onset and progression to end-stage disease at every stage of the condition.